Female pelvic health should include the evaluation and treatments of bowel and bladder, functioning as well as the health of the vulva, vagina, cervix, uterus, and adnexa. However, for many women, when they see their primary or their gynecologist, these other organ systems may get very little attention during the pelvic exam and gynecological review. Today, we're going to focus on the interplay between gynecology and the urological system. Are you the person who feels she has frequent urinary tract infections? Are you dealing with urinary incontinence and/or urinary frequency? Does it feel like maybe there's a fullness in your vagina that feels perhaps like a stuck tampon? Are you aging and the vagina and the bladder just don't feel the way they used to? Welcome to GynoCurious. I'm your host and creator, Dr. Amy Novatt. From both sides of the speculum, we are here to investigate what it means to be a healer and to be healed. Please follow, share, and rate the show. And if you have any questions or concerns, please write to comments@radiofreerhinecliffe.org. And if you're interested in learning more about my new clinical practice, please go to dramynovat.com. Today, I'm thrilled to welcome my guest, Dr. Nicole Fleischmann. Dr. Fleischmann is a board-certified urologist with advanced training in female pelvic medicine and reconstructive surgery. She completed her residency at Albert Einstein College of Medicine, and due to a special interest in the treatment of female urologic issues, she went on for further training in the diagnosis and treatment of urinary incontinence, surgical procedures for incontinence, and pelvic floor prolapse. She uses minimally invasive techniques using the Da Vinci robot to perform complex pelvic reconstructions and runs a robust program in sacral nerve modulation for incontinence. Welcome, Nicole. Thank you for being here today.
Thank you for having me, Amy.
I'm so thrilled. We actually got a chance to say hello before the show, and I kind of wish I had that opportunity with all my guests. I don't. So it was particularly special to spend a few moments with you previously or prior. So most of the urologists I know throughout my career and even today are men. How is it that you decided to pursue a career that was, historically very male-dominated, or maybe still very male-dominated?
Yeah, I mean, I didn't set out to become a urologist. That's, a lot of the things that have sort of occurred in my life, I feel like they've happened to me. And urology is one of those things. I actually started out in general surgery. That was my first love. And I ended up switching into urology after my second year, simply because I didn't know anything about urology when I was picking my specialties, and I had an opportunity to rotate through it as a categorical surgery resident. And I realized I missed something that I really should be doing. And I had a great rotation. And the chairman at the time really wanted a woman to join the residency program because it had been 10 years since a resident had been a woman. And
Wow.
So he kind of courted me, said, I'll take you out of the match. And I said, okay, let's go. I really loved urology. But I actually went into urology to do women's health. I never really wanted to be a men's health specialist. And I don't mean to be mean, but I didn't really like OBGYN. It just wasn't for me. I didn't like the whole baby thing.
Yeah.
Very messy.
It's very messy.
Very messy.
All that amniotic fluid right into your shoes. It's a drag. Yeah, well, that's the beauty of us all having different loves and woes and interests and paths, right? I love learning about how people become the people they are, because sometimes, yes, it's just kind of falls into our laps. Sometimes it's a crystallization of a lot of what feels like very divergent events in our lives. And sometimes, like you were open to exploring something that you didn't understand, and that led you down a path that fed you and helped you realize a career that I hope you love.
Oh, yeah. I mean, I do love what I do now.
Yeah.
But I will say I love it more now than I used to. I wouldn't say I was always in love with my career. It's very difficult to be a doctor, as you know.
Yeah.
There's a lot of pressure and there's a lot of expectations, and people aren't very nice to you most of the time, especially as a woman. And so, I wouldn't say that it's all been peaches and cream, but now actually it is, which I think is nice for younger women to hear who are going into specialties. It can get better once you figure out what you really want to do and how you want to do it, and you do get a little bit more of a say in that as you get older. If you stay in the game, you can't leave the game. That's the thing. That's the secret. You cannot leave the game. Once you leave, you don't get a say anymore. But if you stick it through, at the end of the road, you can pick something and make it what you want if you want to. So I that's what I've done.
Yeah. No, I agree. I've spoken a great deal in GynoCurious about my residency and how difficult it was. And in some ways, kind of traumatic, actually. And it's not a word I use easily, but it was incredibly hard. And I'm not just talking about the usual, lack of sleep, terrible food, but the misogyny, the discrimination that I saw against all of my patients because they happen to be female. So it is such a wonderful shift as you get to be a more mature practitioner.
Do you ever feel bad about that stuff? Do you ever go back and say, I wish I said something then?
Well, it's so interesting you asked that because a very dear friend of mine and a colleague, a woman who was my junior resident, she and I just went back to a residency reunion, and we were asking each other, will you say something to Dr. So-and-so when you see him? Say like, do you realize you were really a disgusting pig and that you said things over the OR table that right now would, justify my seeking legal counsel.
Yes.
And we just decided, first of all, most of these men are now in their octogenarians.
Or they're dead.
They're dead. Or, what were we going to get out of it? So I said to my friend Rachel, I said, now, if they start making inappropriate comments at the event, you bet your sweet ass I'm going to say something. I'm going to stand up and say, no longer. But, when you're a resident, you're so powerless. You are afraid you'll be fired. At least I was. And again, it was a time when there weren't a lot of women. And it just felt so precarious day in and day out. Yeah.
I relate.
Yeah.
You develop a very thick skin.
You do.
That's what I did. So everything just went off my back. I did, and it actually hardened me to a lot of things because I think if someone was insulting me, I didn't even know it. I really didn't know it. I was blocking everything, which isn't really a good thing either. And we can even talk about
Go for it.
But this is how I even talk about my work. It's like learning what you're blocking. Learning what you're absolutely not letting in, because sometimes when you're blocking something, you're actually not aligned with your values and your purpose. And we all felt that way when we were out in practice. I mean, I relate to the things that were said. I mean, I actually think besides not going into OBGYN because of the mess, I did not like the chairman of my medical school. He was disgusting. Mm-hmm. And he turned me off from OBGYN because he called all the women fat.
Oh, gracious.
And even women, he would just say, and it was the way he said it, and he said it not to them, but like, oh, she's just, it was just the language. And it was even to the residents. He was disgusting. And I was like, I don't want to be in this field. I didn't know the women's health field was like this. I'm not doing this. They were much nicer in urology. I'm not even kidding. They were very respectful to me there. Always. And that's one of the reasons I gravitated there.
Interesting. I wouldn't have guessed that because, again, it has been so male dominated. But maybe they appreciated that having a woman was going to expand opportunities for patients and, in fact, teach them something.
So when I was rotating, 50% of the women in the waiting room, 50% of the patients in the waiting room were women.
Right.
And I didn't even know that women went to the urologist. I thought it was the male version of gynecologist, that men do the urology thing and women. I wasn't thinking women have bladders and kidneys.
Right.
I'm a resident. I mean, I'm not a layperson here. I was embarrassed to say this now.
Right.
But they needed a woman because all the patients wanted to see me. And I was the intern rotating. I wasn't even a urology resident. They all wanted to see me because these problems are embarrassing.
Yeah.
They didn't want to talk to the men about them. They felt more comfortable. I'd be like, I don't know any urology, but they said, that's okay.
Yeah.
We want to see you. And that is actually what pulled me into the field because I realized we were really, really missing this gap in women's health of all these women who have urinary problems and they can't hold their pee and all that stuff. And they wanted women to talk to you about this. And there just weren't, when I was training 25 years ago, there just weren't those people.
Yeah. Well, I'm so glad you're doing the work that you're doing because certainly finding a female urogynecologist these days is extremely challenging.
It is, yes.
Yeah. So why don't we talk a little bit about some practical matters, and then I really want to make sure that we talk about your book. And I'm just going to mention it now so those listening can kind of stew in the title because it's so provocative. So it's called The Second Mouth: One Woman's Journey to Decode a Hidden Language for a New Era of Women's Health. So just to let you know, this is a book about the pelvis. And Nicole is going to tell us what the second mouth is all about in a moment. So stay listening. And while you're listening, we're going to talk about just some really common problems that women have been writing to GynoCurious asking me to talk about. So I feel compelled to do so. You and I every day encounter a woman who says, I think I have a bladder infection or I have a UTI. So I would like us just to really clarify the language, because a UTI and a bladder infection are not necessarily the same thing, or are they? So can you help distinguish the two for those listening?
So, I mean, if you want to break it down between UTI and bladder infection,
Yeah.
this is like what's one's included in the other. I
That's
forget.
right.
It's
That's
hierarchical.
Right. That's right.
The
That's
language.
Right.
So a urinary tract infection is any infection. And when we talk about infection, we're talking about usually a bacterial infection. So it's usually some kind of bacteria that we're growing out of the urine. But that can come anywhere from the upper tracts or the lower tracts. So the bladder is a lower tract, meaning it's at the bottom of the body, whereas the kidneys are the upper tract. So you might not have a bladder infection, but you could have a kidney infection, and that is still a urinary tract infection, if that is
That's perfect.
All right. I'm trying to clear up lingo.
Yeah, no, so exactly. No, women will come in and say, I have a UTI. And I'll say, okay, we talk about the kidneys and we talk about the bladder. And they're like, well, I don't know. It's all the discomfort's down there. I was like, well, that would suggest that maybe it's in your bladder. And so let's focus on what might be the etiology and the treatment, et cetera. So first of all, bladder infections, urinary tract infections are extremely common. Up to 60% of women have had at least one in their lifetime. That's pretty astounding. Why do you think that, one, women get these infections so readily? And why do some women get them over and over and over again, and others say, oh yeah, I had it once when I was, 30 years ago and never again?
I mean, to answer this question, I'm telling you, it's a long story, and I'm happy to tell it. But I want to tell you something about urinary tract infections. If I explain to you why women get them, I'm going to be explaining to you why women get every other problem that they get.
Ooh.
Because when you look at the body in terms of symptoms only, like I have a urinary tract infection, or I have incontinence, or I have pain, you're missing the real reason of your problem. Because what I would like to tell you is all women have the same problem, okay? But the symptoms are different. So one of those symptoms might be urinary tract infections. And by the way, not all of these, ouchies down there are actually urinary tract infections. In fact, most of those symptoms down there are not because there's bacteria. We have bacteria in our body. I mean, we know that now. The microbiome is like the huge topic, and
right.
We have it in the bladder. We have bacteria live in in fact, I think we have more bacteria in our body than we have cells in our body. Someone once told me that. I don't know if that's true, but we are like we're kind of like this like symbiotic. So you can't just tell me, oh, I have bacteria in me. That's bad. Well, yeah, your whole body's bacteria. So let's talk about that. But
that's right.
You might have inflammation in your body. And I do know that bacteria like inflammation a lot. It's where they grow. So most of these UTIs are not starting because you have bacteria in you, but you have an inflammatory situation and the bacteria are sticking to it like glue. And then they make it worse. And we know this kind of process when we think about you get a cold or a chest infection and they tell you, well, it's not bacterial, so I can't give you an antibiotic. And then 2 weeks later, you're getting the antibiotic because that thing turned bacterial. It works the same way in the bladder. So it's an inflammatory process that's turning into UTI. Now, why do you have an inflammatory process in your bladder? Well, that's what we're going to talk about.
So you mentioned the real problem. You've said it several times now. So we got to go there. Tell me, what is the real problem that's the cause of so many of the common complaints or challenges that women face around the bladder, the pelvic floor, defecatory problems, etc.?
Okay. The problem is that we don't really have a good concept of how our bottoms work. And this is almost a species-wide condition. We can call it almost like a disconnection. And it's species-wide. It's a nervous system disconnection. And in a way, we can think about it as arrested development. I like to look at it like that. So if you think about how our nervous system develops, it develops top down. which means that as we go from our head down to our bottom, and our bottom is our pelvic floor, that's the muscles we sit on, that's the furthest area from our brains. So it takes a while for all those nerve endings to get down to the bottom. You have to grow a little bit. But it's not just about growing the nerve endings. You have to ignite them. You have to become aware of them, and you have to use them. And we are not learning that part. So because of that, we're sort of nervous system disconnected. And we get away with that for a really long time, but it does make us reflexive in our bottoms. So reflexive means that our muscles are not really under our control, even though they should be. We're supposed to be aware of our pelvic floor and our lower abdominal muscles, but we're kind of not. They're just kind of working on their own. They're squeezing, they're clenching, they're doing all these things without our awareness. And we could say, well, they're doing a great job for us. They're holding things in for us. But actually, that's not true. They're just working and squeezing. And a lot of that happening is just because you're scared or you're anxious. And these muscles are going all the time. And if you're not aware of them and you don't know how to take them down, you're going to start developing problems in your bottom related to blood flow issues. I call it vagina clenching and butt clenching. We're all doing it. If you're not aware of it, you are. And you just have to put your attention on your body to see that you don't need to keep that muscle in a tight squeeze. You're doing it. Just take it down. And the more you notice that it's happening, the more you'll notice that that constant squeezing behavior is what's going to give you a UTI. Yes.
Can you explain that? So, as I mentioned, Nicole and I had a little coffee before we came in, and Nicole started to tell me about her thoughts and ways of thinking about the pelvis. And I was practicing kind of quieting my own pelvis. And it's remarkable. I think of myself as someone who's aware, of my physiologies. And yet it's true. I have lived my life clenching my belly, holding in my belly, of course, and there's a lot of tension in my pelvis. And
we all have it.
It's
global.
Yeah.
So all of us have it, and we've been calling it normal, like we need it to hold in our pee and poop.
Yeah.
But it's not true. It's a lie. It's like we've been sold this bill of goods. I really feel that way, Amy, because I feel like this is stuff that we should have known. I don't think that this is the first time anybody should be hearing this. If you're hearing this for the first time, I'm telling you that that's wrong. There's a problem we're having here, because that process of walking around squeezing all day is infantile. That's what children do. And someone needs to say to you, you don't need to do that. You're not responsible for holding your pee and poop in. Your body does it for you. And if you keep on helping it, it's going to retaliate, especially after estrogen loses. Especially after estrogen, leaves the system. That's what I'm trying to say.
Menopause.
Menopause,
yes.
Yeah.
So can you unpack that for us a little bit further, please? Here we are, we're a child at 2, and we're starting to do what's called, potty training and toilet training. And there's all kinds of psychologies out there about how to do it, best way to do it, how children respond to it. But you're suggesting that things start even from that point on.
Well, that's where the dysfunction starts.
Yeah.
All right. But that dysfunction is normal. See, I want to say, the dysfunction you develop in early childhood is part of the learning process. We have to take baby steps to get places where we want to go. We can't get there all in one day. Some of these processes are very complicated, and we can only learn the first part of it at one time. So the first part of toilet training is about learning to hold. And we're usually ready to learn that about the age of 2 or 3. That's what the studies show. Our brain development is there. Now, there are some countries that toilet train their kids at 6 months. They literally put them over a sink and hold them over. And they just, and to be honest with you, I'm not even sure it matters. I'm not even sure it matters what happens in those years. I think toilet training is messy. That part is messy because you're talking to someone that really doesn't have the language, that doesn't. So it's always going to be messy, that first stage, and kids are not going to get it. And there's a lot of suffering that goes on with that. But most of us grow out of that stage. And we're okay. But the question is, are we really okay? Because there's something we didn't learn, and that was how to release. The release mechanism is way more advanced than a little kid can understand. It takes a more developed brain, and we don't have it at 2 or 3.
And we're talking about the release of urine or the release
Stool
of
and urine.
stool. Okay.
Yes.
So is it fair to say it's analogous to the flexion of a muscle and then the relaxation of a muscle? Is it analogous in
So we can understand how to flex and relax our pelvic floors at the age of 2 or 3. But relaxing is not what we really ultimately need to do. We need to move. There's a movement that needs to happen. And it's not just, so this is a very old paradigm. Well, unfortunately, it's a current paradigm. We're going to have to knock it down. We're in process. It's getting there.
There we go. We're having this conversation. That's the start. Okay. In your book.
Yes. So there is a paradigm that we need to knock down. And it's that the pelvic floor is clench and relax. Okay. It is to a child because that's where the brain development is at that time. You hold and clench and you relax to pee. But it turns out that relaxing is not actually relaxing, which is really where it gets complicated. The act of relaxing requires a coordination with our breath. And that is a neurological milestone. It doesn't happen at 2 or 3. We'd probably need executive functioning to accomplish that.
And that's at about what age?
I would say middle school years. I mean, this is untested when it happens. I mean, we will get there. All of this is going to get there. You're getting it hot off the presses, folks. Okay, just remember you heard it here first on Amy's show. But yes, the actual way to release your sphincter muscle is not by relaxing, because actually that's pushing. It is pushing, and it's how we all learn to pee. Anytime you hold your breath and bear down, that's pushing. And even though you feel like you're relaxing, it's really pushing.
I love this irony, right?
And you're unaware that it's pushing because it works. And it's supposed to work because we have 2 pathways for urinating, okay? One is like the peripheral nervous system. And this is what we use, like people who have spinal cord injuries, they can only pee by pushing because their central nervous system is really cut off from the rest of the body. But we tend to use the same system that the spinal cord injury patients use, and we use it for our whole lives. We're not supposed to be using our peripheral nervous system. We're supposed to be using our central nervous system to pee. And that requires airflow. I know that sounds crazy, but that's how it goes. So when you sniff, that process is going to actually open your pelvic floor. You need to breathe and you need to pee at the same time. It's a coordinated flow.
Okay, for everyone out there, you've never heard this before, as Nicole said, so we got to break this down even further. So is a sniff a particular way of breathing that we need to instruct those listening about? Are we just talking about taking a deep breath? Are we talking about something different? Because as people who have listened to GynoCurious have heard me say over and over again, is we tend to pant our way through life. We are in a rush constantly. We are multitasking. So few people finally stop and let their body breathe deeply or breathe naturally, actually.
But the question is, what does that mean?
Yeah.
So I think we're very confused. And this is also species-wide. Not only were we not toilet trained properly, we were never taught to breathe. And you might say, that's crazy. I've been breathing my whole life. I'm here.
Right.
And I'm going to tell you that you can be a dysfunctional breather and a dysfunctional peer and a dysfunctional pooper, and you could probably live to 100 years old. But you're not going to live in health. You're not going to live with continence. You're not going to live with your nervous system intact, because it is really mandatory for you to learn what breathing actually means for you to maintain health. It's the only way you can. I mean, you can eat right. Yeah. I mean, you can exercise. I'm all for those things too. But step 1 is knowing how to bring air into your body, because there's only one way you're supposed to do it. There's only one way. You could say this is a technique. You could say, but we call it the diaphragm breath. All right. It's kind of, I think Plato was the first person to talk about it. I mean, I don't know. I'm not a Buddhist. You know, I do take yoga now because I think it's good for your joints, but like I didn't learn any of this stuff from a yogi. I'm just talking about the neurophysiology, about how the body works.
Right.
So your diaphragm is a muscle that's like kind of under the rib cage, like it's at the very top of your abdomen. And it's your breathing muscle. It's the one that does the work of breathing. And most of us don't even know it's there, much less how to engage it. And we can't engage it through our mouth. That's the thing. You could push your belly out when you breathe through your mouth, but it's not actually breathing with your diaphragm because we're talking about a brain stimulation here. So you have to stimulate your brain in order to pee. You can't be doing the work of the breathing. The brain has to do it. The only thing that you can do is sniff. So the sniff is the only move, and then you're going to push with it. Okay, you're going to push it. You're going to have it feel that vertical movement of the sniff to the bottom. And what's going to happen for a lot of people is they're not going to be able to do that. They're going to be like, what the hell? This is the hardest thing anyone's asked me to do. And it is hard. It's not hard for you because you're primed for this. You've been thinking about these things for a long time. But for the average person who's not been thinking about breathing, they don't even know what I'm talking about.
Yeah.
It's a foreign language, and they don't understand that they have to feel air go through their body, and it starts with the top of their nose, and that's a nervous system stimulation that allows the bladder to open. Yeah, and I teach it to everybody I meet. It's the first thing you learn when you come to see me as a patient is how to pee. I teach my patients how to pee, and it's also about posture. Because we're all sucking in our stomachs, Amy. And I don't really know where that started, but it's not natural. It's not a natural pose. You know, no other animal on the planet sucks in their guts. Watch your dog, watch your baby, watch your infant. We all come to the planet knowing how to breathe, and then it's conditioned out of us. So at the time where we could probably understand the mechanics of breathing, that you need to sniff to start your breath, because that's how you engage your diaphragm, we're taught to suck it in. At the exact moment when we could really start to get into our bodies and learn embodiment, that's when it's squished out of us.
Particularly as women.
As women.
Yeah.
And there are studies on this. I mean, what I'm talking about, I would not ever, as an MD, I took an oath of truth. I cannot get on, any type of public space and not talk about something that's not evidence-based. So if this is the first time you're hearing this stuff, just understand it's because the evidence is not available to you. Because you're not reading the studies from China. That's me. I'm the nerd going through the literature, reading the rat literature, so that I can bring to you these ideas so that you can understand we know this stuff. We're just not able to formulate these ideas because it goes against everything we've ever been taught.
Absolutely. What I love about what you're sharing with us is, well, there's a number of things, but one of which is this kind of global perspective that you said that, and correct me if I'm wrong, that because we're not breathing properly, all the dysfunctions that we're talking about, whether it's a bladder infection, whether it's pelvic prolapse, whether it's incontinence, et cetera, et cetera, et cetera, and maybe even beyond the urological system, I suspect. This is what I talk about over and over and over again in GynoCurious, that, the knee bone's connected to the shin bone, that every aspect of our life is connected.
So we're in a silo in medicine. Okay. So one of the reasons that I never learned this stuff, that I had to learn it through the study of life and observation and reading, one of the reasons I wasn't trained like this is because our medical field is siloed. It's split into many different sections. So as a urologist, I'm not studying GI. I was actually one of the only people through the urology fellowship that demanded to go through some OBGYN. I wanted to hang out with the OBGYNs. I'm like, I know all the urology. I need to learn from other specialties. So I had to go outside my specialty to understand these concepts better because they were definitely not in my field, but they were in other fields.
Interesting. Well, and each specialty has their own perspective. So if you have the benefit of kind of harvesting all those perspectives, then you get a much more global.
You have to be curious.
You have to be curious.
Yeah.
Exactly. So can you tell us about the second mouth? That is a peculiar title. What are you talking about, honey? Where is this second mouth?
Right. So the second mouth shouldn't be peculiar. That's also the funny thing about it. When you understand what it is, you're like, I should know this. And actually, this is kind of what my book is about. It's like once you understand these concepts, you're like, I know this. But because no one ever gave you the language, you couldn't really understand it the way you're going to now. Okay, so what is the second mouth? It means we have two mouth mechanisms, one on each side of our body, and they are kind of mirror images. Okay, which is very strange. But when you look at the embryology of how we form, it's not strange at all because the neural connections have always been there. And the people who scream about this are the physiatrists and the OTs, but my profession doesn't really, listen to them. But they're right. There are connections. And if you want to talk about cranial sacral stuff, all that voodoo, it's not voodoo. It's actually tapping into some very real concepts that we have not accepted in allopathic medicine. Why? Because they're very hard to study in an evidence-based way. However, they are only hard to study in an evidence-based way now. Now is the key word because technology is going very fast in these areas, and it is only a matter of time till everything is going to be proven correct. Okay, and we're not going to be able to say, oh, I don't see a randomized controlled study on the second mouth. Well, you know what? We're going to have that because the technology is going to allow us to get there and we're going to be laughing about it because we're right. Okay? But anyway, what is the second mouth? You have two mouths. And if you think about where your chin is, your real chin, you have a chin, an analogous chin on your lower back where your tailbone is. Okay, so your tailbone functions just like your chin. Okay, and if you think about it, you have a closed mouth until you move your coccyx back. And it literally moves back, but it only moves back with air pressure. Now, how do you put air pressure into your body? You have to use a pump. That pump is going to come from your sniff. It's the only pump we were given, the only man-made pump. Okay, so when you take a sniff, you're pulling air to the pump on the other side. And if you pay attention to your tailbone, you'll feel it move back. That's your second mouth. Yes, you have to sit forward.
Jen, our engineer, is doing it as we speak.
Okay, so Jen, put your finger under your nose like a mustache. Lean forward a little bit. Let your belly out a little bit and just sniff. Yes. Feel it?
What am I feeling?
Put your attention on your vagina. Okay. You feel it open. You opened your second mouth.
Okay, bravo.
So now that we know what the second mouth is, it's a control mechanism we all were born with, but you have to tap into it. Someone has to tell you it's there. It's there. And when you learn how to use it, you learn how to release urine and stool from your body the way God designed us, to open our bottoms on the other side. But you got to keep your lips closed. And it's really understanding how air should enter your body. This is how we're supposed to breathe. So when we talk about breathing, it's an embodied thing, okay? Breathing is what brings embodiment. And when I say that, breathing is what lights up your nerve pathways. I'm not like some yogi. I'm talking about neurophysiology here. The act of breathing is going to awaken your brain to how your body is in space. That's how you develop postural control. So if you're unbalanced, it's because you're not breathing properly. If you learn how to bring air to the other side of and you can't use your chest at all, no chest movements in this. You're bypassing your chest. You're going right to your diaphragm. It goes to the bottom. Yes, you got it. So you see, we can all learn to breathe normally and it feels so good because that's also how you regulate your nervous system.
Absolutely. The minute I started doing it, there was a kind of calm.
It's Valium.
Yeah.
It's nitric oxide from your nasal passages and it's turning into gabapentin and that is Valium and it's being released throughout your body. And if you don't believe me, just do it. You'll feel the Valium. And let me tell you, when you hit 50, you need constant Valium. You need it. You need a pump of Valium just a give me Versed.
Indwelling.
I know. I'm jealous of the patients on the table. I'm like, can they just put a little Versed in here because I have no nervous system regulation right now. You know what I mean, Amy.
I know what you mean, Nicole. Yeah. So we're talking in a way, literally the way we're speaking about the body, not in an allopathic language way. And you and I grew up in the world of allopathy. We grew up in very conventional settings. We both went to, schools everybody knows about and all that stuff. So how has it been for you on a personal level and professional? Because it's hard for us physicians to kind of really pull those tendrils apart. To learn this long-known science to become aware of something that none of your colleagues are talking about. And most of your patients are probably going to look at you initially like you're a wackadoodle.
You're going to love my book. That's what this is about.
Okay.
So this is what my book is about. It's about how I came to learn this and what I did at the time when I realized with certainty that I was correct, and how I started presenting it to my colleagues and the kind of responses that I got, and how difficult this is, because this is not how we are trained. The problem is that if we don't hop on this bandwagon pretty fast, we're going to lose all of our patients. Because if we don't start addressing these problems for what they really are, which is lack of nervous system coordination, we have to rebuild the field. We just have to rebuild the field. We have to include this. This is part of it. We have to re-toilet train the world. We have to teach people. And by the way, I know you think this is just about women. It's not. It's about men too. Men also suffer from these things, but they suffer differently than we do. And we suffer more because we have children. So we damage our bottoms not knowing how to open them. When we don't know how to open, we're pushing through closed doors and we're literally distorting our tissues and tearing. And I don't think that we're supposed to be doing that. I think we were all made perfect. And I think childbirth was supposed to be perfect too. I think it's a matter of skill. And I just don't think we've learned it. And I think we can.
Yeah, it's interesting. I mean, imagine, there was a tremendous amount of when those who taught breathing techniques for childbirth first came on the scene, boy, did they get a lot of ridicule. Nobody would believe that breathing alone, breathing in a certain pattern, being aware of one's breath could help assist in decreasing not only pain during childbirth, but decrease
the second stage of labor,
that's
which
right,
is where we get the prolapse.
That's right.
And decrease the second stage of labor, right?
Yeah.
So that's where we're seeing the problems, because it's that prolonged second stage of labor. And it's because the woman does not know how to release her pelvic floor. And if you've delivered a baby, and I haven't delivered that many, it's been a long time. I have a lot of friends who are gynecologists who talk to me, because I have a lot of friends I talk to about this stuff. And a lot, by the way, I don't want you to think that people don't get this. When I talk to doctors about this, they do understand, because this is stuff we all are, that's in front of all of our faces. We don't have the language. It's just not in our training.
Right.
But, for the second stage of labor, if the woman does not know how to release her pelvic floor, the baby is going to have a really hard time getting out. And I think about it like if you're at your dentist and you're going to get your tooth drilled and he says, open your mouth. Like if you couldn't do that and the dental assistant was like holding your jaw down, I mean, it just wouldn't be as easy. Like you'd be resisting and they would say, can't you just open your mouth?
Right,
I mean, why do I have to open your mouth for you? That's what childbirth is like right now. Plus they have us on our backs instead of on all fours so that we can't even benefit from the actual, that's how it would help us open the bottom a little bit easier and we wouldn't have to think about it as much. But, these are things we've just gotten away from our animal behaviors. We think that we're not animals and that our neurology is still animal. We can't change that. And the neurology is what determines how our muscles move. We can't change that. We have to understand it so that we can go with it, because every time we try to go against nature, we're going to get killed. Nature always wins. We don't have any power.
I mean, you could use that as the next title to your next book. I mean, because
I'm not going to share that with you, but it's not the next title. But I will say a lot of things that I think you feel the same way about, because we're in this camp.
Yeah. So for those listening who might be saying, okay, I get it, I've got to open my pelvis, what would be some of the strategies for them to begin to really embrace this in their lives so that the pelvic floor is healthier, so that prolapses aren't happening to them, et cetera, et cetera?
Okay, I'm going to tell you the way that I think it can be done.
Okay.
You have to change your form in your brain. And what I mean by that is that we all have an idea of what we look like or how we should look, what we're striving to look like.
From the you mean the
just our external
phenotype.
form.
Okay,
just our how we stand. Like what do I am okay. So I would say I'm a straight back, flat bellied creature. That's me. I'm a straight back, flat bellied creature. If you think that that's what you are wrong. You are not a straight back, flat bellied creature. You're either a straight back, round bellied creature, or you're a flat bellied, curved spined creature. You cannot, something has to give, because otherwise you're in a state of organ compression. There's no space for your organs to live. This is just physiology. Okay. So you got to let your belly out so that you can have a straight spine. And I do a lot of postural maneuvers with my patients to get them to let their belly out. The abdominal disengagement, the ability just to release your muscles. Like you did a great job, Jen, but I have to say that like this is a thing that people can't get. They don't know how to do that maneuver. It's a postural maneuver. They don't even know they're sucking in. It's totally unconscious. And I have women that are like this big. They've never let their bellies out in their entire life. They're suffocating.
Yeah.
They're suffocating. And I feel so bad for them. Like, you don't have to hold your belly in like that. Who told you to do that?
Yeah.
It's awful. I see people suffocating now.
Yeah. The corseting of women has been going on, well, forever.
But even when the corset came off, we've kept it on.
Of course. Exactly.
It's invisible, but it's around us. And
Yeah.
we're not breathing. We're not letting our bellies out. We're not using our diaphragms. And when we don't use our diaphragm, you can't use your diaphragm unless you sniff. That's how you're supposed to breathe. So just understand, if your diaphragm's not going out every time you inhale, not exhale, you're not getting blood flow through your body properly. You're not getting blood flow into your brain properly. Your nervous system is not, you're cutting off parts of your nervous system. Every time you clench a muscle, your brain can't see it. It's like you're cutting off your nervous system. So a lot of women who feel numb in their vaginas, they're just clenching so tightly that the nervous system is literally, it's like having an amputation. It just doesn't see it anymore. The first time you take down the clench, all of a sudden you're like, oh my God, I have a vagina. I'm not even kidding. It's these nervous system disconnections, they're real. If you ask a woman, you could touch her vagina, she'd say, I don't feel it. Because she's clenching so tightly, her nerve endings have gone.
Yeah.
So it's like, and it's unconscious. That's what's so sad about it. I'm like, if you're clenching, I want you to know it.
Yeah.
If you decide to clench, go ahead and do it. But if you're doing it unconsciously, I just feel like you're walking around with spinach in your teeth and nobody's telling you.
So it strikes me that particularly in my field, many of my colleagues talk about the Kegel exercise. And they routinely tell women, particularly as they're aging, do your Kegel exercise, do your Kegel exercise. And many of them are not asking the question of, is the Kegel exercise really the right thing for these women? Because as you're pointing out, so many women are walking around with clenched pelvises already, and that the source of their prolapse is not necessarily hypotonus, the lack of tone, but hypertonus, too much tone, too much clenching.
There's nobody that doesn't have a hypertonic pelvis. Nobody. There's no such thing as a weak pelvis. You can weaken your tissues. Mm-hmm. You might be born with weak tissues. I mean, some people have these very elastic tissues. It's just genetically handed down.
Right.
They're stretchy people.
Right.
You all know who you are.
Right.
And, yes, is that weakness? We could debate it. But I feel that our bodies are pretty much designed perfectly. So how your tissues are there to support the type of person that you are, the type of movements you're planned to do. Just your nervous system knows how you move, and you're born that way. But if you're ramming through your tissues every time you're on the toilet to poop, yeah, they're going to drop.
Yeah.
And that's just a lack of coordination, So your muscles are staying closed, and those weak tissues that you were born with are starting to herniate out. That's how prolapse develops. If you would just learn to open your bottom on the toilet, your tissues wouldn't herniate out.
I don't know if this is apt or not, so bear with me. Sometimes when we talk about the pelvic floor in the past, we think of it as a kind of a trampoline. And I'd like to translate the trampoline metaphor into this second mouth. Can you do that for us?
Oh, absolutely.
Good, great.
When I talk about it, you're going to understand, because I told you the chin is your tailbone, right? The whole back of your vagina is your pelvic floor. Okay. And it actually goes all the way to the tailbone. So the pelvic floor is a group of muscles on the back of your vagina, not the front. Okay. There's no part of the pelvic floor that's at the, where your belly is. It's all on the back of you, where your butt is. Okay. So it goes from the back of your vagina through your glutes, all of that. And the tailbone is the chin. Okay. So this whole group of muscles moves back and forth. And if you think of it like a jaw, if you open it, the jaw's down, and then when it's in neutral, you're in closed position. But then you could also do this Kegel maneuver, which I call it teeth clenching. Okay? So the pelvic floor is just the jaw of your mouth. That's all it is. And that mouth is a mirror image of the back. Does that make sense?
It's the jaw of the pelvis.
It's a pelvic jaw. So if I put my finger in your vagina,
right,
and I just press down, that's the jaw.
That's right.
And when you do the perineal, thing, when you push it down, you're opening the jaw.
Right.
It's where the jaw is. That's the pelvic floor. Now the butthole is going to be in the middle of that. When you look at the patient under,
right.
You'll see the butthole go up and down. That's the pelvic floor.
Right.
And that's what you can move, but you can only clench it. That's all you can do until someone shows you how to move it back with a sniff.
Right. So help us understand. So what about incontinence? Paradoxically, incontinence feels like a phenomenon where everything is, as we use the word relaxed or dysfunctional with regards to the muscles that control everything. Tell us about how you understand incontinence, which again is such a common problem. Some of which is what we call stress incontinence, which is the loss of urine when we cough and sneeze. Some of it's urge incontinence, where we got to go, and we can't really store our urine. So it's a little bit interesting. It's very interesting, but a little hard to appreciate how incontinence works vis-a-vis the mouth.
No, it's so much easier to understand it.
Good. Tell us. Tell us.
See, here we go. We've separated urge incontinence, stress incontinence. We've confused ourselves again into categories. I think even just how we think about incontinence is wrong. Okay. Most women have what we call mixed incontinence, which they have stress incontinence. They're leaking when they cough and sneeze, but they also have, a little bit of running to the toilet. So the way I think about incontinence is how you're balancing your clench and your hold.
Yes, exactly.
It's real. And we're not supposed to be holding in our pee anyway. So if you're an older person and you are clamping all day long, you're going to start leaking in your pants. And you're not going to realize that you're leaking because you're clamping. You're just going to think your bladder's getting more overactive. We don't understand that when we start to move our pelvis normally, and when I say normally, we stop walking around clenching and let our bladders hold it for us. Everything works fine. You don't have to worry about or you're just holding. You're just holding your pee. Your bladder's not leaking all over the place. Now, leakage when you cough is usually there's one of two reasons why you leak when you cough. One is a neurological problem where you're clamping so tight. And I see this a lot with young kids who are runners. Okay, so the track kids, the 16-year-old track kids, they're peeing all over the track. Why? Because they're so tight. They're holding themselves in so tightly, and they're running, and their reflexes are not working. Okay, so the reflex to clamp is not working. That's the only time the guarding reflex is your friend, I say. But if you've had a child and you've ripped stuff because you haven't opened your bottom, okay, you're going to misalign your sphincter. You're going to misalign it. It's not going to close properly anymore. And that's sometimes a surgical problem where we have to realign things for you. Sometimes we put it in a sling. But at the end of the day, it's just because your sphincter has been damaged because you haven't opened the door. The sphincter you can't strengthen with a Kegel. The Kegel, you just have to not damage your sphincter. Let's put it that way. There's no strengthening exercise you can do to strengthen your sphincter muscle. So don't even bother. It's not going to work.
So there's so much to talk about, and I've already decided you're going to come back to the show because I think there's just so much to unwrap here. Because what you're describing, what you're revealing to us is so against what we have all learned. It's just uncanny.
It's the idea we have to wake up.
We have to wake up.
We just have to wake up. I'm sorry to tell you that I don't agree with anything. I don't know what to say. Once you see this for what it is, it's like when things start to make sense, you've just got to go with it. I'm just sorry.
No. Thank goodness there are thinkers like you out there because, the fact is that we are a very sick population. We have so much chronic disease. Women are so unhappy with their pelvises, and it should be a part of their body they adore and love and cherish and
we
worship.
At any age, we can, but we have to understand how our pelvis works or we are never going to get there.
Yeah. Yeah. So it sounds like that's what our next conversation has to be about, is really trying to understand how from a very early age, so we teach our children, and if we're already adults, how, and you're listening to this, well, okay, it's not too late. Is it too late? Okay.
When is it too late? When you've lost nerve, when your nervous system has started to change permanently. If you have a neurological disease, if you're dealing with Parkinson's or Alzheimer's, I'm probably not going to be able to re-toilet train you.
Yeah.
But and I've toilet trained people who are 100. I swear, if you have the right motivation, you can learn this stuff at 100. And it works.
Great. So it sounds like it not only works in improving urination and defecation and the health of your bladder, but your overall health. And that's what we are here to talk about and scream out loud about, that it's all connected. So it sounds like we all need to sniff more, and we all need to feel the airflow all the way down to our pelvis, and that
and keep your mouth closed. Don't cheat. No chest movements.
Okay. And that it can be done, that it can be done. So I want to just remind everyone, I'm speaking to Nicole Fleischmann, MD. She's written this book, The Second Mouth, One Woman's Journey to Decode a Hidden Language for a New Era of Women's Health. Please, please, please take a look at it, because it's going to explain even further what Nicole has shared with us today. And before I say goodbye, I love to ask my guests what gives them pleasure. If you had to say one thing that you enjoy in your life that gives you joy, what would it be?
I know this is going to sound corny, but I should say my hot tub, because I love my hot tub. I mean, that does give me joy. But what really gives me joy is being on this podcast and feeling like people are starting to listen to my voice, because that is the only thing I want. I feel like my voice just needs to be out. I don't care who you are. You just need to hear this message. You need to toilet train.
That's great. I love the idea that we're talking about toilet training, because it is so rife with challenge and hardship for parents. And it sounds like it might be a much easier thing to do than we know about.
It can be easier for all of us and for the kids. Remember what we suffered.
Yeah.
A lot of us have been suffering for a long time with this, and now we'll have a voice.
Yeah, great. Well, that's what GynoCurious is all about, is giving voice to a lot of conversations that are kept in closets or never spoken out loud about, and that you and I get to share our stories and our journeys with everyone out there. So thank you, thank you, thank you. Yeah. And thank you to my co-producers, Maddie Rosenberg and Jen Hammoud, and David Hoffman, my editor. Thank you to the Epicurean for hosting us here in Rhinecliff, New York. Until the next episode, please be well. Listen to your instincts and intuitions. They are the greatest of teachers, not to be ignored. And I want to remind listeners that this podcast is for general information purposes only and does not constitute the practice of medicine, nursing, or other professional healthcare services, including the giving of medical advice. And no doctor-patient relationship is formed. The information on this podcast is not intended to be a substitute for professional medical advice, diagnosis, or treatment. Users should not disregard or delay in obtaining medical advice for any medical condition they may have, and should seek the assistance of their healthcare professionals for any such conditions. Be well out there.